My name is Dr. Edward Ngwenya, and herein we will be continuing with our series on the genitalia. Genitalia, of course, we've touched on perineal recon. We've gone through most of the embryology and the anatomy of the genital urinary system, and with particular emphasis to the genitalia. We've also spoken about penile reconstruction and penile scrotal defects that we may have. And in this series, I think it's for us just to speak about the vulvovaginal defects that we may have. And perhaps we'll see how the session goes. If we have enough time, we can just touch on the principles of transgender surgery. What is transgender surgery, and what do we aim to then do when it comes to transgender surgery? The let's start by saying, as I say in all my sessions, this does not aim to replace your learning, but merely to augment it. And thus, I encourage you to go and study the anatomy. We've dealt with the anatomy extensively, so this brief, I'm not going to deal with that, and the embryology therein. Let's go into the vulvovaginal defects that you may have. Now, of course, this is an intricate topic, and this is just a high-level, succinct overview of the subject matter. So, just a quick run on the anatomy on a high level. What is the vulva? What is the vulva? What do we refer to? The structure is composed, obviously, of the clitoris, the labia minora, and the labia majora, and then we will then have our vaginal cavity, wherein we will have the anterior, the posterior, and the lateral walls, which define our boundaries up until, inferiorly, or rather, if you look at it on a superior aspect, the posterior inlet would be where the cervix, which is the inlet to the the endometrium, which is the uterus. The cavity to in there would be the cervix, posteriorly blocking the area therein. So we are on the vulva. What do we have? We've got the clitoris, which is derived from undifferentiated phallus, and it has paired corpora, the vestibular bulbs, and it has glands, so that's where it comes from, and it would liken, if one may say, as per differentiation, to the glands in the male penis. And so then we've got the labia minora, which are folds of skin that do not have fat, and they are the internal ones, and the maximum distance from the base to the edge is relatively 4 centimeters in terms of criteria for labioplasty. And then we've got the labial majora, which is skin, campus fascia, Colles fascia, basically the continuation going into the abdominal scarpus fascia, that being Colles fascia. And it has an inferior attachment on the ischopubic rama that actually prevents the spread of hematomas and infections that may be inferiorly so. However, as I've mentioned, the Colles fascia is continuous in the abdominal scarpus fascia, and certainly if you have, any infection which may come from there, as you may have, abscesses forming therein, which may go up as a necrotizing fasciitis up into the abdominal skin, and so you got to deal with those, and urgently so. The arterial supply is from the internal pudendal artery, the superficial and deep external pudendal artery. And of course, you would then have your testicular, or rather here, ovarian arteries, which branch off the aorta, where the gonads would generally originate from. So let's look at our internal pudendal, which would have branches, it come off rather. It would, from there you'd have your inferior rectal artery, your perineal artery, which then supplies the perineum, and the vulva. The vulva is the equivalent of the male scrotum. And then from the perineal artery, then you'd have, your posterior labial arteries, your dorsal and deep arteries of the clitoris that would then go there. So if you look at it superiorly to inferiorly, looking at the blood supply, the deep artery of the clitoris would lie right up there, and then you'd have your dorsal artery of the clitoris. Then you have your posterior labial arteries, which then would have the perineal arteries going lower down between the perineum between the vagina and the rectum, and then your inferior rectal artery coming right off from your internal pudendal would then supply the anal components, the sphincters, etc. So all from the internal pudendal, and then we've got the superficial and deep external pudendals, which branch off, the medial side of the femoral artery, and then they supply the skin of the lower abdomen and generally anastomose with the internal pudendal artery to supply the genitalia. So the blood supply generally good. Innervation also quite good, which is the 2 pudendal nerve and the ilioinguinal pudendal nerve, S2, S4, following the course of the internal pudendal artery, and would branch, therefore, inferior rectal perineal nerve, where you'd get your deep motor branch, those going to the labia, the posterior labia, and the dorsal nerve of the clitoris. And the ilioinguinal from L1 would go to the anterior labial, which, the root of the mons, and upper part of the labia majora. And so generally that would be the anatomy therein. Now let's get into vaginal defects. Now, how do we then classify these as per etiology? They may be, as we define in all things, congenital or acquired. Congenital anomalies, either it's absent or it's malformed. Absent, what are we speaking about? Vaginal agenesis. Vaginal agenesis, also known as your MRKH syndrome. I always have to think before. Let's think if I remember. MRKH syndrome is Meyer-Rokitansky-Kuster-Hauser syndrome, I think, but I just remember it as the Rokitansky syndrome. So that's complete vaginal agenesis. But you may have segmental absence, which example may be an imperforate hymen or a long segment atresia that you may then have. And then you've got malformations. Just like we have in males and females, we also have female hypospadias that may then occur. And then the other part that we have then is acquired vaginal defects, and they may be induced from certain different pathologies, such as surgically or radiation induced colpocliasis, we call it colpocliasis, and there may be cancer, there may be trauma, from birth I don't know, during childbirth, we get that quite common infection, chronic inflammatory disease, and just iatrogenic injury. I don't want to go too much into the etiological causes. Perhaps one that you should perhaps know a bit about would be vaginal agenesis, your Meyer-Rokitansky-Kuster-Hauser syndrome, and that's basically absence of vagina, and it's something that occurs. The range goes from 1 to 4,000 to 1 to 80,000 births. And in essence, the cause therein is a defect in the mesonephric duct development or fusion of the urogenital sinus with the paramesonephric duct. And so you would, of course, get urinary anomalies, which would include ectopy, duplication, agenesis in as far as 50% of the time. But these patients typically present with normal development of secondary sexual characteristics and normal external genitalia. And so when we then examine them, clinical findings can be separated into two types. Generally, genetic female with or without a functioning uterus and absent vagina, versus another group where you've got your genetic female with or without a functioning uterus with absent vagina and anomalies of skeletal, urinary, and digestive system. So they tend to have more, which is involved herein. And so you diagnose it from the history you've gotten clinically. You do your pelvic exam. Important to do, intravenous pyelogram for these patients just to check and rule out your urinary abnormalities. Geneticist is very imperative to work with for karyotype screening. And then, of course, we've mentioned that you can get the second type, which has abnormalities of skeletal, and digestive system. So a spinal, X-ray will help to rule out any vertebral anomalies. And so the way we would then, manage these patients, of course, is reconstruction. And the problem is that generally, if you intervene in childhood, as we found that vaginoplasty in childhood has poor results, and so we tend to defer these procedures, until puberty or just after puberty, which is even much better. And the first line is always dilatation. And so there are different techniques that you may use for dilatation. There's pressure dilatation techniques, which can be, just creams or pursaries. And so patients would use these estrogen creams, and you may use this in conjunction with dilators, but generally it results in a cushioning, if you may, of the vaginal tissue and making it more comfortable to use dilators, if you may take it in those terms. And so there's intermittent pressure, continuous pressure. That's how I like to divide my dilator techniques into intermittent or constant. Constant is your, Vecchietti technique or procedure, which is laparoscopically done. And so basically you use traction sutures that allow a pool. You attach a plastic bead internally about 10 to 12 centimeters, and then it allows that pool for a number of days, 10 days perhaps, or 7 days. And this is quite good because it gives your constant pressure. Whereas, others such as your Frank Ingram's procedures is patients who would do self-dilatation. And generally, this is BD twice a day with a rounded rod-shaped appliance. And then you just apply gentle pressure, just enough to cause mild discomfort. And typically, would use it for about 20 to 30 minutes twice, per day. And there's good results with this. And hence we advocate that every patient should have a trial, but 90% success, rate in really motivated patients. So these are your dilatation techniques. And then, of course, there's your surgical vaginoplasty techniques. And what do we then do? Simply, there's, when you can choose, you use skin graft techniques, and it depends where you take your skin graft from. So you can either take your skin graft from, in terms of, transgender surgery, from the penile, penoscrotal skin flaps that you may use. However, in these patients with vaginal agenesis, we would then use what's described as the McIndoe procedure, where you use non-genital skin grafts. In essence, you have this vault, you put in a line skin graft, so you dissect a tunnel in the perineum just above the rectum and below the bladder, all the way to the peritoneal reflection, and then you line this entire cavity with split thickness skin graft. Others have said use full thickness skin graft, and that's, Sadoff-Horton procedure, which is just a variation. Or others, as Peshama would say, use amnion, which is better as it becomes gradually replaced by vaginal epithelium. But whatever you use, as per McIndoe, they use split thickness skin graft, and then you put it there. But of course, we know the main problem is the strong tendency for graft to contract. And so how do we prevent this? It requires dilatation or intercourse daily to assist in keeping that there. Now, if you're not going to use that as an option, there are local flaps that you may use, your vulva, bulbocavernous flaps that you can use, your vulvoperineal flaps. Many have been described, your Malaga flap, which is a vulvoperineal flap, or your pudendal thigh flaps, something certainly I've used, the Singapore flap. Just know how to mark a Singapore flap, because I think many residents really get this quite wrong. But it's important just to know your markings of a Singapore flap. And the nice thing about it is that, it brings sensate fasciocutaneous tissue that's there. And in essence, the advantage is it's a simple technique. It can be completed in a short space of time with very limited blood loss. Flaps quite robust in their reliability as per blood supply. We know this, of course, uses the internal pudendal artery, or rather the continuation of it, which is the superficial, the terminal branch of the superficial perineal artery, and the superficial branch of the perineal artery then would supply this, and the nerve is the posterior labial artery of the pudendal nerve, and the perineal branch of the posterior cutaneous nerve of the thigh would assist in that. And so you can raise them bilaterally. No stents or dilators are generally required, and the angle of inclination of the vagina is quite physiological and natural. But we know there may be vulvar pain, in terms of patients who've got excessive hair growth in that area. Now you know what you can then cause, and chronic discharge, and also imagine protrusion of the flap, and that is something that can be very, very devastating and discouraging as per, sexual intercourse, when you have this flap now protruding. And so how do you raise it? Should we go into? Okay, quickly. Just know that you want to, base or rather put your patient in a lithotomy position. Your landmarks, of course, you design it on non-bearing hair skin in the groin crease lateral to the labia majora. And what do you do? What's your posterior border? The posterior border will be the posterior border of the vagina. That's what marks the posterior border and the base of the flap, which is the posterior wall. And then laterally, of course, you use your labia majora just beyond the hairline, or rather the hair-bearing area. It would then be then your medial border. So you've got your medial border as the lateral labia majora, and then you measure generally 6 centimeters wide is how you want to measure it. Remember, we've said the base is at the posterior fourchette level, and so you measure 6 centimeters wide and generally 15 centimeters long as per the pedicle. Remember that you may be, what limits your proximal would be the femoral triangle, and so it will, the distal, or rather the distal margin, if you look at it in a lithotomy position, will then be the femoral triangle. And so the important, you then mark, it cuts around those flaps, you elevate it from proximally to distally. Remember where the internal pudendal artery lies. It lies in the, in the triangle that you are going to mark, that's created by the fourchette, of the vagina, the anus, and the ischial tuberosity. So ischial tuberosity, the fourchette, the anal, then you will have your internal pudendal coming in from the bottom there. And that's your supply. So knowing that, it means up until when I reach my fourchette, the level of the fourchette, in dissecting my flap 15 centimeters generally, then I've got an area that I can actually undermine, and that's about generally 4 centimeters posteriorly. So you would raise it and elevate it through a subcutaneous tissue to the deep fascia. You go all the way to the deep fascia, and so you raise it, the lateral and the medial margins on each side. However, when you reach that level, you can then add just on a subcut level, you then can undermine about 4 centimeters to then get that bit of excess, so that you can then move it. And in essence, if you find that you struggle a bit, you can excise a skin margin through the dermis to the subcutaneous tissue, generally a depth of about 1 to 1.5 centimeters. And this allows you then to undermine, and the flap to be transposed about 70, even 90 degrees to meet its fellow on the opposite side, and allow the posterior rim margin of the flap to be stitched to the labia minora. So that makes it great to use. So just know your Singapore flap, how it's raised, and where your markings are. Regional options that we have, we've got the Davidoff technique. And what is the Davidoff techniques? Basically, it uses the peritoneum that you would free from the pelvic side wall to line a newly, excavated vagina, and it can be performed laparoscopically, that being the advantage. There are other flaps, your gracilis myocutaneous flap, noting the size, of course. There's the rectus abdominis, whether you use it as a tram, but VRAM is better as it can reach. And then ACA, SIEA, superior inferior epigastric artery flap, you can then use. And let's not forget the last option and final option, which works very well, vascularized bowel segment. Whether you use your rector sigmoid, your ileum jejunum, those work very well. The ileum quite good, rector sigmoid quite thick, or rather, quite large. But you can take a segment of the ileum or the jejunum, and it works well. Look, of course, there are problems therein. What are the problems? The length, the texture and appearance, very good, quite similar to the natural vagina, and it gives natural lubrication, but it can be excessive, this production of mucus, and it can also be quite repulsive at times, and you may need care, because the mucosa is so thin, and it can be vulnerable to bruises, the bleeding, and thus making it easy for STDs or HIV. Others would mention that, but of course there's the morbidity now of an additional abdominal surgery that you would then need. And so those are your techniques generally. So whatever you are faced with, let's assume you've got an acquired defect. Acquired defect, we've mentioned, generally it's trauma or cancer, colorectal or bladder, and what you want to do in acquired, because you don't have complete agenesis, you then want to look what portion or which portion has been taken. And so we classify them according to the Cordero Classification. Remember, Cordero classifies them based on two types. Type 1, it's a partial defect. Type 2, it's a circumferential defect. Therefore, part 1 would then say, look, if it's would divide into A, B, and C. So type 1A would be the lateral wall is involved. Type 1B would be the anterior wall is involved. And type 1C would then be the posterior wall. So it's either the lateral walls on the side, the anterior wall, or the posterior wall that is affected. And so the management would depend. And then the last one is a circumferential defect, that's type 2. And Cordero mentions it as D or E. So type 2A rather can be, a partial circumferential. In other words, it's only the upper 2/3 that's involved. And then the other is the entire vagina, as you would get in a vaginal agenesis. And Cordero, he recommends certain measures to then assist in these. And what are the measures? For a partial defect, if it's the anterior wall, as per Cordero would say, look, an anterior wall or a lateral wall, Singapore flap, well, rather, you'd use a modified Singapore flap, works perfectly. And then your posterior wall, rather a rectus abdominis flap. So, because of course of the position of where it would lie. And then if it's circumferential, what Cordero recommends would say, if it's the upper 2/3 only, I recommend a rolled rectus abdominis flap. But if it's total, then I would recommend a bilateral gracilis myocutaneous flap. And if you keep that bilateral, you can go around with it and have still, a good sphincter mechanism therein. So as would be used generally even for anal reconstruction when the sphincter is lost. Now, exceptions to this algorithm would be a morbidly obese patient, the elderly, or significant comorbidities. So that's something that is put there. But just note that, look, you've got to define your goals before, and the goals are preferably a single stage procedure. Just so it can help to facilitate further therapy. And then you want whatever flap you're gonna use, you want adequate anatomical dimensions and orientation of the wall of the defect. And then you want to eliminate any pelvic dead space that may be, and replace or rather restore the pelvic floor to prevent any herniation. And of course, we want function, which is the restoration of sexual function and body image. Therefore, the minimum maintenance or requirement for dilators is something that to be factored in. And in all that we do, we want to minimize our donor side morbidity. So we want function, but with less limitations and more durable function. And so what are the options? We've gone through the options. Your modified Singapore, your vertical rectus flaps, bilateral gracilis, or then a colon transfer. Never forget that. What are the complications? We divide them into early, into late. Complications that are early: infection, delayed wound healing, flap loss, and then late, of course, inadequate or excessive vaginal secretions, depending on what you use. and flap prolapse, hypertrophic donor site scarring, urinary bowel complaints, abdominal wall hernias, if you use now the rectus abdominis. So you would then specify those dependent on what you are using. What shall we talk about now? I think vulval defects, we've kind of covered them. Generally secondary to cancer, squamous cell carcinoma coming high up on the list. That's 5% of all vaginal genital tract cancers. And the majority, of course, as we've said, squamous cell carcinoma is the predominant one, 95% of the cases. But don't forget, you can have melanoma, sarcoma, basal cell carcinomas. And certainly two pathways mentioned here. In young patients, think of HPV that contributes to disease. And in older patients, then you look at chronic vulval irritation or lichen sclerosis as a cause. But surgery, always first choice. And patients would generally undergo bilateral lymph node dissection. And so in severe cases, we may need adjuvant radiotherapy. Thus, the reconstruction options that we want to then use are durable ones. And medial thigh flaps work well. I've used even VY advancement flaps, a pedicled ALT, depending on the patient, you can also use. And so I think generally, as we've mentioned, you another thing you can use for your own mind, as published in the CME, I think in 2017, is just dividing your defect and then having a plan of how to use it. It's a a defect in the upper third, in the middle third, or in the lower third. Upper third is the mons pubis to the labia, middle third, the labia, proper, and then lower is the vaginal orifice and the perineum. And so you will then design your flaps in accordance. And generally, upper third, they'll tell you, look, you can close it, you can use small local flaps, rhomboid, V-wide, split skin graft, but a large defect, generally greater than 20 squared centimeters, you want to close. And what can you use? A polycode ALT. It's there, giving you versatile cover there. And if the mons defect includes any pelvic dead space, you can even throw in an omental flap that can be used in addition to the ALT. Middle third, we've spoken a lot about the pudendal flap, very good. Gracilis, myocutaneous flap. I'm not going to go through the gracilis. I think that's something you can look. And gluteal fold flaps, your eye gaps, you can use those ones. Just be careful of the reach sometimes, but generally you can. But gracilis is very good, excellent alternative, to the pudendal flaps. In the event that your zone of injury being the area where the pudendal flap is, it might preclude you from using it, such as radiation therapy received in that area. And so if I don't have those local flap options, a gracilis certainly something that I can easily put. Very simple, easy in lithotomy position, feeling where my tuberosity is tubercle is, and then feeling where my medial wall of the or medial condyle is of the femur, and then just feeling for my adductor. And then when I feel for the adductor, I know that within that line, 10 centimeters down would be my pedicle. It is a type 2, of course, having segmental supply coming from lower down. And so great option to then use gracilis. What's important though to know about the gracilis, whether you use it as a VAG or a tag, VAG just vertical, it cuts there, or the tag, it's a transverse skin pedal that you then use. It's difficult with the skin pedals, just know, because the muscle is actually a bit deeper than you think in terms of supplying those. So the skin pedal, not so reliable. However, look, it's there, it's been mentioned. Just noting your blood supply would come about 10 centimeters lower down. So as you make your incision, one thing to always keep is, of course, to know and separate it from the semi the sartorius, because it's so close, it goes right there, but and the tendons may be so difficult to separate. So I like to do a small incision lower down, first look at my vessels, my tendons, and then I pull. I just do some attraction test, and you would then see if it's the gracilis that's pulling or the sartorius, which actually you would then see the direction is a bit different. But that's the way. Blood supply, medial circumflex femoral artery, and then you would have segmentals, either from the superficial or deep, femoral lower down. So gracilis definitely good. I said I was not going to describe it, and there I go and describe the gracilis. But that's fine. At least now you know how to do the gracilis. And then the best for the lower third, people will throw in gluteal fold flaps, as described by Yi and Niranjan. But Hashimoto modified it in the late 90s. And so generally you mark your gluteal fold preoperatively with the patient in a standing position, and then the flap is located in the triangle formed by the ischial tuberosity, anus, and vaginal orifice. Remember, I've mentioned that's the triangle there, and so you then know, then your blood supply would then run there. And that, I think, should take care of vaginal or vulvovaginal defects. What did I say? I said we may, if we get a chance, speak about gender reassignment. Should we do it? Okay, let's speak about transgender. I'm going to be very high level. I'm not going to go into, the terminologies. You must know what gender dysphoria is, and you must know what, the classification of disorders of sexual differentiation. How do you classify, DSD? And there are basically a number of ways. Just look at the newer guidelines, and they will generally tell you where we are now with DSDs, because the classification keeps changing. But transsexualism, very important. It's got 3 criterias in order to diagnose, and just know, how do I differentiate this gender dysphoria, which basically describes a heterogeneous group of individuals who expect or rather express varying degrees of dissatisfaction with their anatomic gender. That's the issue, their anatomic gender, and they then, have the desire to possess the sexual, or rather secondary sexual characteristics of the opposite sex. Whereas now with transsexualism, that's a bit different. If you look at it, there are 3 criteria actually. 1, the desire to live and be accepted as a member of the opposite sex. And this is usually then associated with a wish to make his or her body, as congruent as possible with the preferred sex through surgery and hormonal treatment. There's our difference with gender dysphoria. And then the other criteria then is, transsexual identity must be there present for at least 2 years. So present, not only present, but persistent for at least 2 years. And the disorders, of course, as in every criteria, should not be a symptom of another mental disorder, chromosomal abnormalities. So this term, generally transsexualism, it was abandoned because it often, it was criticized for implying a sexual disorder as opposed to an identity disorder, and therefore this has been replaced by the term gender identity disorder. But nonetheless, I think what you need to know is the management therein. What is the approach, therapeutic approach that you would take. So in essence, high level, you want to break it into three. There's the single, the aerial test, real life experience in the desired role is one, then two, hormonal therapy, so hormones of the desired gender, and then lastly, surgery to change the genital and other sex characteristics. So what this, just understand, it was defined by the World Professional Association of Transgender Health, and these are the guidelines for diagnosis and treatment, the WPATH, I call it the WPATH, the World Professional Association for Gender Health. And this is after, Harry Benjamin. And so it's then a two-stage approach, the first being the diagnostic phase and the second being the treatment phase. Let's divide it into those two. Works easier for me. The diagnostic phase, there are two stages, all right? Let's call them A and B, stage A and stage B. Stage A would last about 6 to 12 months. And what does that involve? Basically, we want to diagnose if this is definitely a true, thing, or a true conviction, rather, that one has. So we want to define the exact form and tenacity of gender dysphoria and its severity, and actually the sexual or transsexual conviction. And then we want to also ascertain the degree, that those individuals fulfill the requirements. And as I've mentioned, and we want to give information. So generally during this, you are working with, your psychiatrist. You want to pick up additional problems, biological, perturbations, and exclude basically patients who you don't think meet this criteria. So once you've decided this, now we go into a period of a year to about 18 months where it's stage B. And generally now this is the real life test. So we say now is the real life test. We're putting you then, it's time, to experience this, to confront this, the subject basically with the everyday reality of him or she, or what he or she will meet once the sex reassignment process has been completely successful. So the subject then takes on the role of the desired sex in everyday activities, whether it's socially, professionally, and many patients generally need to be taught. They need to learn a more feminine demeanor if it's male going to female. And this period, as I've mentioned, then it will last for 12 to 18 months. And supportive psychotherapy is important in this process. Once we are clear and this has passed, then we enter the treatment phase. And that's also divided into two. And the first one, I like to divide it also into two phases. So the first is hormonal treatment, and then the second is then the surgery. Hormonal treatment, what is it? So you work with your endocrinologist who confirms the absence of absolute contraindications, and then we start the hormonal. Some centers mix this hormonal treatment with the real life test, but generally we like, in my setting, we don't. We separate them and we start for 1 year first. The first thing is generally the male to female transsexual, a reversible chemical castration would then happen. What do we use? We then use medications that will suppress the patient's own sex hormones. So this is a suppressive phase for a year. And then after we go for a substitution phase where we use hormones of the opposite sex. Once we've gotten that, we done. The last and only thing then left, which will happen, until a year after starting hormones, I like at least 2 years after the first psychological consultation, then you would then start your surgical measures. And what surgical measures can we give? If it's a male to female, the male is generally, breast augmentation, a rhinoplasty, male pattern hair removal, so they may want laser, a reduction of thyroid cartilage, and feminization genital surgery such as a penectomy, penile inversion skin graft, intestinal substitute, whatever you use for a neovagina. And we've spoken about different things, but here the use of a pedicled penile and scrotal skin flaps has been described, as long as 40 years ago. And that remains certainly the mainstay for neovaginal construction. And this vascular basis of these flaps is derived from one of three vascular axes, either the deep external pudendal artery, which is a branch of the femoral artery, the superficial perineal artery, branch of the internal pudendal, or the funicular artery, which is a branch of the deep inferior epigastric artery. And, generally good technique, you create this natural appearing vagina and a mons pubis. Really, it can look really good. It removes the stigmatization of the scrotum, and you then can have actually a sensate neoclitoris that you can then form. That's what you want. And so you will then look at your other labioplasty techniques that you can then put. But labioplasty can be done under local anesthesia in an outpatient department after vaginoplasty. And generally, it's just to create convergent anterior commissure and provide additional clitoral hooding. And that is it. For the male to the female, or rather for the female to a male, the surgical interventions that we've put would be what? Breast amputation or breast reduction, hysterectomy or oophorectomy, and then phallus reconstruction. And this we speak a lot about, in perineal, or rather in the penoscrotal defects. Neoscrotum are also something that you can do, various procedure. I'm not going to go into it, but meato, or rather meatioplasty, is what is then used. Say generally, the surgeon, after we've gone through the treatment, for the overdevelopment, generally you would give treatment, hormonal treatment to overdevelop the clitoris, and then you do elongation and displacement of this clitoris construct. You call it a microphallus, and then you lengthen the urethra to the tip of the phallus using anterior musculomucosal vaginal flaps, and that's good. Advantage, you maintain sensitivity, erogenous sensitivity, and you avoid extensive scarring associated with more complex techniques. But disadvantage, 50%, they won't be able to void while they're standing, which is fine. But the issue that it may also create a very short phallus that will not, usually allow sexual intercourse. And so you may then look at other techniques. But that is the meatido diaplasty. So that's it. And I think we've covered much of the procedures. Take care. Bye-bye.